Hello, this is the Global Perspectives on Sexual Violence Virtual Symposium held on September 24th at the Lyda Hill Institute for Human Resilience at the University of Colorado, Colorado Springs. Unfortunately, due to some technical difficulties, the intro to this symposium does not occur until after our first speaker. So in just a minute, you will be hearing the recording of our first speaker, Dr. Jillian Shear, who will be the first of 3 presentations on the symposium focused on sexual violence among minority and understudied populations.
Well, welcome everyone. I'm excited to be here to share with you a little bit about my work on physical and sexual victimization, class membership, and alcohol misuse and consequences among sexual minority and heterosexual female youth. I would just like to take a moment to thank my co-authors for this study, Dr. Antevi Gruska and Dr. Tammy Sullivan. And I would like to just take a moment to note that the research presented here is the author's own, does not represent the views of the NIH, and we have no competing financial interests to disclose. Okay. Physical victimization, such as being physically attacked, and sexual victimization, including experiences of attempted or completed non-consensual sex acts or non-contact sexual abuse among youth, represents an urgent public health concern, as many of you know. In nationally representative samples, up to 13% of adolescents report physical victimization, with female youth reporting more severe physical victimization compared to male youth. Between 5 and 8% of female youth report experiencing sexual victimization, including rape or forced sexual intercourse. In addition, at least 35% of female youth with histories of sexual victimization are likely to experience subsequent victimization, otherwise known as re-victimization. And among nationally representative samples, 20% of young adults report victimization occurring in dating relationships, with female youth reporting more frequent and severe forms compared to male youth. Okay. Oh, and just so you know, it says my video is not being enabled by the host. So just in case that, let's clarify why my video is not being shown. But evidence demonstrates high rates of physical and sexual victimization among sexual minority female youth. So these are female youth who identify as gay or lesbian, bisexual, or another non-heterosexual identity compared to heterosexual female youth. And these are disparities that are largely driven by the societal stigmatization of sexual minority identities or minority stress. And studies suggest that between 50 and 85% of sexual minority women report lifetime sexual victimization experiences, with research consistently suggesting that bisexual women are particularly vulnerable to physical and sexual victimization and re-victimization. And although these studies confirm the substantial burden of victimization among sexual minority women in general and among bisexual women in particular, consistent findings have not emerged among youth. So research is needed to extend previous findings by examining victimization rates between sexual minority female youth and heterosexual female youth, and among heterogeneous sexual minority female youth subgroups. For example, comparing female youth who identify as gay or lesbian and those who identify as bisexual. And these findings hold promise to inform targeted intervention efforts for at-risk youth. For both sexual minority female youth and heterosexual female youth, behavioral health outcomes, including alcohol misuse, such as binge drinking, and consequences such as riding with a drinking driver and drinking and driving, have been linked to physical and sexual victimization. And one longitudinal study found that female youth who experienced physical and sexual victimization in dating relationships were more likely to report binge drinking compared to female youth without such experiences. Many female youth who experience physical or sexual victimization may misuse alcohol to avoid, reduce, or manage trauma-related outcomes, such as negative affect and interpersonal disconnections. And further, negative reinforcement models suggest that alcohol use may reduce distress, which reinforces continued and potentially increased binge drinking and consequences. We know that alcohol misuse is especially pronounced among sexual minority youth compared to heterosexual youth. For instance, sexual minority youth are 2 to 5 times more likely to report underage drinking than heterosexual youth, with sexual minority female youth reporting particularly high rates of alcohol use. And while the gender gap between male and female youth may be lessening in this regard, As depicted here in this figure, this finding might not extend to sexual minority youth. And research suggests that risk and protective factors for drinking among heterosexual female youth, such as victimization, family support, may differ for sexual minority female youth, contributing to this group's increased rates of alcohol misuse relative to other groups. We also know that sexual orientation disparities in binge drinking during adolescence continues into adulthood, with the largest rates of alcohol misuse among sexual minority women. However, alcohol misuse may not be disproportionately elevated among all sexual minority female youth subgroups compared to heterosexual female youth. And as depicted here, research has historically conceptualized and measured victimization using variable-centered approaches. For instance, studies among sexual minority female youth samples have primarily relied on total severity frequency scores of sexual victimization by type, or a composite score of the number of victimizations types, or using a mutually exclusive measure of lifetime victimization, such as no abuse, just child abuse, both childhood abuse and adult abuse, or the presence of each victimization type separately. And these studies typically demonstrate that behavioral health correlates are often a function of severity, frequency, and the number of victimization types. And epidemiologic studies of trauma-exposed women document differences in health outcomes by victimization type. Mixture modeling approaches, on the other hand, such as latent class analysis or LCA, can assist in identifying latent subgroups of female youth based on distinct combinations of victimization versus others. For example, based on the timeline, such as recent or lifetime, based on the tactic used, for example, forced sexual intercourse or physical violence, and the context, either occurring in dating relationships or potentially not occurring in dating relationships. And this information can be helpful in screening female youth who might be most at risk for physical and sexual victimization, and alcohol misuse and consequences who might benefit from domestic violence or rape crisis services. They could help differentiate alcohol-related treatment needs, for example, focusing on preventing alcohol relapse versus reducing drinking and driving among youth, and developing trauma-informed integrated prevention and intervention efforts. This is not advancing here. Sorry. Okay. Using a population-based data set of female youth across the US, we first examined sexual orientation disparities in victimization, alcohol use, and consequences. We aim to expand on the youth-based victimization research by using person-centered statistical methods. So to do this, we used LCA to uncover classes of female youth reporting distinct combinations of victimization. And third, we aim to examine sexual orientation differences in victimization class membership. And finally, we sought to determine whether alcohol misuse and consequences differed across victimization classes. The participants in the current study were from the National 2017 Youth Risk Behavior Survey, or the YRBS, which is a school-based cross-sectional survey. And this uses an independent 3-stage cluster sample that's designed to obtain a nationally representative sample of students in grades 9 through 12 who attend public and private schools across the 50 states and District of Columbia. Participants in the YRBS, participation is anonymous and voluntary, and students complete a self-administered questionnaire, and it adhered to local procedures around parental consent, and a weighting factor was used to apply to account for non-response and oversampling. I won't go through too much detail here, but participants reported demographic information such as age, sex assigned birth, race, school grade, sexual orientation. Participants were asked about frequency of past 12-month bullying at school and online, and these variables are used as covariates. Alcohol misuse and consequence variables included binge drinking in the last 30 days. For example, how many days participants had 4 or more drinks in a row. Riding with a drinking driver and drinking and driving, and all alcohol use variables were treated as dichotomous, and their time frame was the past 30 days. And then our victimization variables included lifetime's experience of rape, past year's sexual victimization, and then past year sexual victimization and physical victimization occurring in dating relationships. As well, the victimization variables were treated as dichotomous given the study's focus on advancing knowledge of the clustering among female youth with an accumulation of victimization risk, which is consistent with some epidemiologic approaches that model adversity exposure. Participants were 7,185 youth who were assigned female at birth and identified their sexual orientation as heterosexual, about 77%, bisexual, about 12%, and gay or lesbian, about 2%. Most participants identified their race as white, about 53%, followed by multiracial, which was about 17%, and there was equal representation across grade levels. As you can see here, a total of 80.7% of female youth did not report victimization, which is encouraging. However, 7.7% reported past year's sexual victimization, 7.4% reported lifetime rape, and 4.2% reported multiple forms of victimization. And overall, sexual minority female youth were more likely to report all forms of victimization, especially lifetime rape and past year physical victimization in dating relationships compared to heterosexual female youth. Bisexual participants were more likely to report victimization and past month drinking and driving and binge drinking than heterosexual female youth. And sexual minority female youth subgroups did not differ in their victimization and alcohol misuse. Okay. As you can see here, we estimated models of physical and sexual victimization latent classes ranging from 1 to 6 classes. The 4-class LCA solution was deemed optimal based on model fit indices and model comparisons. I won't go into too much detail here, but as you can see, kind of these gross estimates, the first class represented what we termed polyvictimization. So this was characterized by high probabilities of exposure to lifetime rape, past year sexual victimization, and past year physical and sexual victimization in dating relationships. And this included about 4% of the sample. Our second class, as I mentioned previously, was a no victimization class. So these are folks who had low probabilities across all victimization forms, which represented slightly over 80% of the sample. Our third class was past year sexual victimization. And this was characterized by high probability of past year sexual victimization, a moderate probability of past year sexual victimization in dating relationships, and low probabilities of lifetime rape and past year physical victimization in dating relationships. And finally, our fourth class was lifetime rape class. And this was represented a high probability of lifetime rape, a moderate probability of past year sexual victimization, and low probabilities of past year physical and sexual victimizations in dating relationships. And these last two classes had a little over 7% of our sample. Okay. Results from our multinomial logistic regression model, regressing class membership on sexual orientation, revealed that gay or lesbian female youth compared to heterosexual female youth demonstrated lower odds of being in the past year sexual victimization class and greater odds of being in the lifetime rape class than those in the no victimization class. In addition, bisexual female youth compared to heterosexual female youth demonstrated greater odds of being in the past year sexual victimization class and the lifetime rape class than in the no victimization class. And there were no differences between gay or lesbian and bisexual female youth in participants' likelihood of being in our 3 victimization classes compared to the no victimization class. And finally, results from these 3 binary logistic regression models, regressing alcohol misuse and consequences onto physical and sexual victimization class membership. We had a wall test that indicated victimization class was significant predictor of past month binge drinking, past month riding with a drinking driver, and past month drinking and driving. Specifically, female youth who were in the past year sexual victimization class demonstrated greater odds of reporting past month binge drinking and past month riding with a drinking driver compared to female youth who were in the no victimization class. And female youth in the lifetime rape class exhibited greater odds of past month binge drinking, past month riding with a drinking driver, and past month drinking and driving compared to female youth in the no victimization class. So overall, the present study helps us better understand the patterns of physical and sexual victimization regarding timeline, tactic used, and context among female youth. We learned about sexual orientation disparities and latent class membership, as well as the alcohol misuse correlates of these classes. And the study's findings highlight the importance of considering person-centered approach in modeling victimization and alcohol use. That is, female youth may report certain combinations of victimization that might not be directly observable when you simply examine bivariate associations. And in line with previous studies, findings from this study present alarming rates of various forms of physical and sexual victimization, as well as alcohol misuse and consequences among sexual minority female youth, especially bisexual female youth. And our study's findings provide needed insights into factors related to sexual orientation disparities in alcohol use and consequences among female youth above and beyond bullying. And this is a well-established predictor of alcohol-related outcomes in this population. And female youth in all three classes characterized by relatively high probabilities of victimization, classes which were primarily made of sexual minority female youth. Again, we're at increased risk of alcohol use and consequences compared to those who reported no physical and sexual victimization. And these findings build on prior research by underscoring that regardless of recency, type, and context, sexual violence and physical violence might exert a proximal influence on female youth's vulnerability to alcohol use and consequences. Moving on to research implications, future longitudinal studies should probe the nature of and risk and protective factors for engaging in alcohol misuse among those who report multiple forms of recent and lifetime victimization. Studies should also use microlongitudinal approaches to examine the proximal temporal influence of victimization on alcohol misuse and consequences. And although this study demonstrated sexual orientation disparities in female use alcohol use, future studies would benefit from including trauma and transdiagnostic constructs such as trauma centrality, thoughts of self-blame, to examine some of this psychosocial trajectory that we found in this study. Moving on to clinical implications, these studies' findings bear several important notes for settings including school and community centers for female youth, government organizations, and clinical practice. So, for example, interventions could include comprehensive sexual and physical violence prevention efforts that are inclusive of sexual minority female use experience. Government-produced driving safety promotional experience could include increased risk for alcohol-related drinking behaviors among sexual minority female youth. And finally, trauma-focused behavioral health interventions developed for female youth who experience lifetime or recent sexual victimization are especially warranted. And finally, it's important to note our study had several limitations. Our study was cross-sectional, so causality cannot be inferred. Second, variables were assessed using single items, which can impact the construct validity and interpretability of our findings. Third, participants might have answered affirmatively to both lifetime rape and past year victimization, sexual victimization based on the same incident. However, our latent class analysis revealed that female youth who endorsed past year sexual victimization had low probabilities of lifetime rape. And finally, this study did not include, questions about the perpetrator's identity or relationship to the survivor, the context with which it happened, or any additional tactic-related items like whether the assault was alcohol involved, all of which represent important nuances to further understand victimization and behavioral health correlates. And that is all. So I will go ahead and stop sharing. Okay, thank you so much.
Thank you so much, Jillian. Hopefully everyone can hear me now. Can you give me a thumbs up, Jillian, if you can hear me? Okay, thank goodness. Well, it wouldn't be a virtual event without technical difficulties. So let me do a little welcome, a bit delayed. All right. There we go. So welcome to the Global Perspectives on Sexual Violence Virtual Symposium hosted by the Lyda Hill Institute for Human Resilience here at the University of Colorado Springs. I'm not Elise Dunkley. I'm Heather Littleton, the Director of Research Operations at the Institute and the chair of the symposium. Because we're running behind, I will make my remarks very brief. All right. So the agenda, we fortunately got to hear from Dr. Scheer already today, but I'll provide an overview and then we will listen to the rest of our presentations. And then at the end of the webinar, we will have time for a Q&A and some discussion. So to give you a little bit of background of the impetus for the symposium, in 2017, the International Society for Traumatic Stress Studies commissioned a sexual violence briefing paper. This was the second briefing paper that ISTSS decided to put together. I was fortunate enough to chair that briefing paper, which consisted of sexual violence scholars from the United States, the UK, Germany, Spain, and South Africa. This was published in 2018. However, in the process of producing this briefing paper, it became apparent that there are a number of severe gaps in the literature with regards to sexual violence. For one, we didn't know much about the prevalence of sexual violence in many global regions of the world. While we know that certain marginalized populations are more vulnerable to experiencing sexual violence, we really know very little bit about their experiences with sexual violence, including their recovery, the prevalence, and so on. And finally, while a lot of research is focused on the role of individual and microsystem factors in affecting risk for sexual violence, help seeking, and recovery, there was much less research on macro, ESO, and mesosystem factors that might affect sexual violence prevalence, recovery, and help seeking. Okay. So based on that, I pushed for this special issue, and I was fortunate enough that Psychology of Violence agreed to publish a special issue on sexual violence with 3 goals. The first goal was to highlight work that either synthesized and or expanded what is known about different aspects of sexual violence, including its prevalence, and particularly in global regions where we know very little about it, as well as meso, exo, and macro system factors that might affect risk, recovery, and or help seeking. The second was provide a forum for researchers seeking to understand sexual violence among marginalized and understudied populations. And of course, to spur future research on these aforementioned topics. And fortunately, this, I'm very excited to announce that the special issue is in this month's issue of Psychology of Violence, and it was co-edited by myself and Dr. David DeLillo. And we are also fortunate that authors of all of the articles in the special issue are presenting today. And so these presentations are going to be sort of grouped into 3 different themes. The first is sexual violence among minority and understudied populations. And of course, we just heard Dr. Shear's presentation on that. Next, we'll hear from Stephanie Lim and Kayla Saul. And finally, we'll hear from Jolene Yamid. The second area are macro, meso, and exosystem factors in sexual violence. And we'll hear from Tiffany Marcantonio and Dr. Terry Weaver and Dr. Anna Segura. And then finally, closing out our presentations, Dr. Emily Dworkin will present on a systematic review of the global prevalence of sexual assault. So thank you everyone for being patient there. And I will stop sharing my screen. And next, Kayla and Stephanie will take over.
Thanks, Heather, for that introduction.
Okay, perfect, Stephanie. I'll let you take it away.
All right, so hi y'all. We're Stephanie and Kayla. And today we will be presenting our team's paper, Minority Stress and Sexual Partner Violence, Victimization and Perpetration Among LGBTQ plus college students, the moderating roles of problem drinking and social support. And this paper, our co-authors are Dr. Katie Edwards, Laura Sear, Heather Littleton, Lori Wheeler, and Donna Chen. So what we know from the literature are the high rates and deleterious outcomes of sexual violence among emerging adults, including sexual violence that occurs within the context of a current or former romantic and sexual relationship. Additionally, there are especially high rates of sexual IPV among individuals who identify as lesbian, gay, bisexual, queer, or some other non-heterosexual identity. And the literature also suggests that experiences of minority stress increase risks for IPV. Although research has found that hazardous drinking and social support are related to both IPV and minority stress, the extent to which these two moderate the association between minority stress and sexual IPV, victimization, and perpetration is unknown. Therefore, the purpose of the current study was to assess distal, such as stigma consciousness, and proximal, such as internalized homophobia and sexual identity concealment, minority stressors as predictors of sexual IPV victimization and perpetration among LGBTQ+ college students, as well as the extent to which hazardous alcohol use and social support moderated these relationships. So the data comes from our larger project, the Student Health Adjustment and Relationship Experiences Study, SHARE, which seeks to assess campus climate and LGBTQ+ students' experiences of IPV. The data was collected during the fall 2019 and fall 2020 academic terms. And students were invited to participate through emails, ads, and as well as university and social media postings. So the current study was a cross-sectional design and utilized a sample of LGBTQ+ college students across 20 institutions of higher education in the US. Participants were between 18 to 24 years of age and identified predominantly as white and women. To assess for our variables of interest, we use these validated measures, and our analytical approach used structural equation modeling with moderation to evaluate if the association between minority stressors and sexual IPV victimization and perpetration were moderated by hazardous alcohol use and social support.
Okay, so our results, just a friendly reminder that our minority stress latent variable had 3 indicators. So internalized homophobia, identity concealment, and stigma consciousness. So we had, from the theoretical model we displayed earlier, we had 2 models. So the first panel is the perpetration of SIPV, and the second panel is victimization. So regarding perpetration, minority stress was not related to perpetrating SIPV, and there was a significant interaction effect between minority stress and problem drinking, with a significant simple slope of +1 SD above the mean, which indicated that with higher levels of problem drinking, minority stress is associated with a higher likelihood of perpetration of SIPV. Regarding the second panel of victimization, so minority stress and problem drinking were associated with greater likelihood of reporting SIPV victimization. And there's a significant interaction between minority stress and problem drinking, indicating that in situations of high problem drinking, minority stress is related to greater likelihood of SIPV victimization. So interestingly, on-campus social support was not related to SIPV victimization or perpetration. It's possible that among LGBTQ+ students, their on-campus social support was leading to risky behaviors such as greater engagement in problem drinking, or it's possible off-campus social support reduces the risk of SIPV greater than on-campus support. Additionally, hazardous drinking was related to SIPV victimization, though not SIPV perpetration. And this may be due to the small sample size of SIPV perpetrators in our study, or that hazardous alcohol use functions differently with SIPV perpetration versus physical IPV perpetration, which we know that the majority of research is focused on that physical IPV. Minority stress also had a direct impact on SIPV victimization, but not perpetration. So similarly, at higher levels of hazardous drinking, minority stress was related to SIPV victimization, but not perpetration. It's possible that those who engage in lower levels of hazardous drinking may rely on healthier ways of coping with minority stress that reduces their risk for SIPV. So like with all research, there were some limitations to this study. our participants were overwhelmingly white women and bisexual or pansexual. So that really limits our generalizability to more diverse samples. This study was also cross-sectional in design, which is going to limit our ability to make temporal associations. So how minority stress, hazardous drinking, and what am I trying to say? Social support function over time. So there are also very few instances of SIPV perpetration, which may have reduced our ability to detect significant associations. I believe in our sample of 1,200, about 33 people indicated instances of perpetration. Also, there were pretty low rates of hazardous drinking in this sample. So that also limits our ability to evaluate problem drinking and its association with SIPV. Lastly, there was likely selection bias to participating in our study. You can notice our rainbow themed recruitment materials and share logo. So it's very possible that individuals who are experiencing minority stressors or SIPV were less likely to enroll and participate in this study. So this study has multiple implications. SIPV prevention efforts for LGBTQ+ students should really focus on reducing minority stress and hazardous drinking. Prior research has supported that providing normative feedback to students can reduce hazardous drinking. However, none of this research has been specific to LGBTQ+ students. Further, although minority stress did not have a direct influence on SIPV perpetration, LGBTQ+ college students could still benefit from programs that seek to reduce proximal experiences of minority stress, meaning internalized homophobia or identity concealment, given the numerous negative health outcomes that are associated. And importantly, there are programs for reducing these proximal experiences of minority stress in LGBTQ+ individuals. However, this work has not been conducted among college students specifically. So recent research also suggests that existing programs to reduce IPV are effective among heterosexual students, but they do not reduce IPV among LGBTQ+ students, which emphasizes the need for tailored programming for this community. Additionally, college campuses should consider creating inclusive and safe campus environments for LGBTQ+ college students by instituting policies that reduce structural forms of sexual stigma. So overall, there's a clear need for culturally grounded and affirming prevention efforts to reduce SIPV among LGBTQ+ college students. And here are our references. There are many more in the actual paper. And here is a list of all of our Share Study team members, as well as our grant number from the NSF. And that concludes our presentation, I believe.
Thank you, Dr. Littleton. Hi, everyone. I'm Jolene Yamin. I'm a doctoral student at Wayne State's clinical psychology doctoral program. And I'm going to try to share. One moment. Sorry, one second, having some technical difficulties. Can everyone see this?
Yes.
Yes, okay, thank you. So I will be presenting our paper titled Arab American Women's Health Following Sexual Victimization, an exploratory study of the moderating effects of bicultural identity harmony and social constraints. And this was co-authored by my lab mates in the Stress and Health Lab at Wayne State, Hannah Holmes, Shoshana Kroner, and our advisor, Dr. Mark Lumley. So I'll start with just try to keep the background as brief as possible, and then I'll move on to the study itself. Sexual victimization, obviously, it's very well established that sexual victimization experiences are linked to a host of health problems, and that negative social reactions to disclosure of victimization experiences are linked with poor post-victimization adjustment and health outcomes. And we also know that women from underrepresented groups, such as racial and ethnic minority groups, face unique sociocultural challenges in recovery from sexual victimization. And specifically, I'll be talking about our study population, which is Arab and Chaldean American women. Arab Americans are individuals who trace their ancestry to or have immigrated from Arabic-speaking countries in the Middle East and North Africa. Chaldean Americans are an ethno-religious minority group that has immigrated from northern Iraq. And though the Chaldean language is different from Arabic, and Chaldeans are primarily Catholic rather than Muslim, Arab and Chaldean Americans share many linguistic, cultural, national, familial identities and characteristics. Therefore, we included both in our study sample, both Arab and Chaldean Americans. And this population is very underrepresented in health research, generally speaking, but sexual victimization is particularly understudied in this population. And so we sought to examine the impact of sexual victimization experiences on health symptoms in this population, particularly somatic and psychological symptoms, and also understand potential moderating effects of several cultural and social factors on the relationship between victimization and health. And so one important construct to consider when working with individuals who have to navigate two distinct cultures is the idea of bicultural identity. And so for Arab American women, it's having the complex task of engaging in two distinct cultural identities, traditional Arab culture and mainstream American pop culture, especially when it pertains to issues related to sexuality. And bicultural identity can be examined via the framework of bicultural identity integration. And it generally is understood in two components: cultural harmony versus conflict, and cultural blendedness versus compartmentalization. Harmony captures the degree of compatibility or clash perceived between two cultural identities, whereas blendedness captures the degree of overlap or dissociation perceived between the two cultural identities. And low bicultural identity integration overall is experienced as internal conflict and stress, and is also associated with a sense that one must choose just one culture with which to identify. So it creates a lot of conflict. Although harmony and blendedness are part of the same overall construct, they are distinct and they are linked to distinct outcomes. For example, low cultural identity blendedness is linked to personality and performance related challenges such as lower openness to new experiences, greater language barriers, and living in more culturally isolated surroundings. Whereas low cultural bicultural harmony is linked with other variables such as higher neuroticism, greater perceived discrimination, and more strained intercultural relations. And furthermore, bicultural identity harmony is the factor of bicultural identity integration that is most associated with health. It's been found that lower bicultural identity harmony is linked with higher perceived stress and cortisol reactivity, and suggesting that perceived conflict between one's cultural identities can negatively affect health. So given the relationship between bicultural identity, harmony, and blendedness, and health outcomes, and the differing sexuality related norms between Arab and American cultures, it's likely that the bicultural identity integration overall may impact post-sexual victimization adjustment among Arab American women. And another construct to consider when examining sociocultural factors that may impact assault recovery in this population is the idea of social constraints. And these are social constraints are perceived when individuals feel alienated from and unsupported by their social network and feel discouraged from expressing trauma-related thoughts, feelings, and concerns. And high social constraints have been linked to poorer post-trauma adjustment and elevated distress. And this construct also tends to be culturally influenced. So for example, specific to Arab culture, some of the constraints that may exist here related to sexuality include relatively conservative sexual norms, the fact that discussing sex is taboo outside of discussions with one's spouse, And the idea that engaging in sexual activity goes against maintaining family harmony and preserving familial honor. And also the gendered stereotypes related to not being pure for engaging in any sexual activity, or also fears of shame for not protecting oneself. So all of these things could lead Arab American victims or survivors of sexual assault to not bring up or not disclose these experiences to another person. And this may augment the impact of sexual victimization because of the lack of disclosure and also the potential lack of help seeking post-victimization. So our study hypotheses were that, one, that sexual victimization will be associated with greater health symptoms, as we've seen in the literature more broadly, and that low bicultural harmony and blendedness and high constraints will be associated with greater health symptoms. And we also predicted that bicultural identity will moderate the relationship of sexual victimization to symptoms, in that the association will be strongest among women with low bicultural harmony and low blendedness. And then we finally predicted that social constraints will also moderate the relationship between victimization to symptoms, in that the association will be strongest among Arab American women with high social constraints. Our participants were a sample of 120 Arab and Chaldean women recruited from the Metro Detroit area in Michigan. They were primarily a young sample, primarily college students, though some were also recruited from the community. And I will note that they were initially recruited for a study that was designed to test the effects of a sexual health focused interview on health. So that was the purpose of the original study, and I have it cited here. And here's just a breakdown. So we ended up with 120 women with full data on key study variables that we included in these analyses. Just to briefly mention the sample characteristics. So the majority of the women were from Iraq or Lebanon, majority first generation, and about an even split in terms of religious affiliation between Muslim or Catholic or Christian. In terms of our procedures, we had the participants complete online baseline measures, and those included the study moderators, so bicultural identity, integration, and both somatic and psychological symptoms. And then during the 60-minute interview, we collected a wide variety of different variables, and this is where we examined sexual victimization. So data from baseline questionnaires and interviews were analyzed in our study. And here are the measures that we used. The sexual experiences scale was initially designed to assess for experiences since age 14 and after. We did modify that to include lifetime experiences, but because we were interested in getting that, so I will make note of that. And then also we combined the depression and anxiety scales from the brief symptom inventory to form a measure of psychological measures, because they were the two scales were highly correlated with one another. And in terms of our analyses, the sexual victimization variable was dichotomized in our sample because it was significantly skewed. So we coded individuals who did not report as 0, ones who reported 1 victimization or more as 1. And we examined for correlational analyses, the association of predictors with the 2 symptom measures. And then we also use the Hayes process macro model 1 for our moderation analyses, testing bicultural identity and social constraints as moderators. And for our findings, overall of the 48%, so about 40 or 33% of the women reported at least 1 victimization experience, whereas the majority reported no history of sexual victimization. And although we did not use the types of victimizations endorsed in the analyses, again, because we dichotomized the victimization variable, I just thought I would note here that these are the different types reported, and I'm happy to answer any questions about that. For our first hypothesis, consistent with our first hypothesis, sexual victimization was positively associated with both somatic and psychological symptoms. And we also found, so our second hypothesis was partially supported in that social constraints was positively associated with both types of symptoms. However, bicultural identity integration was less consistently related to symptoms. So as you can see here, bicultural identity blendedness was unrelated to both types of symptoms, and bicultural identity harmony was inversely related to psychological symptoms and was marginally inversely related to somatic symptoms. The P was 0.06. For our moderation analyses, again, our third hypothesis was partially supported in that bicultural identity harmony moderated the relationship of sexual victimization to somatic symptoms and psychological symptoms. So as you can see here, sexual victimization was associated with higher symptoms, both types of symptoms, only at low and moderate levels of bicultural harmony, but not at high levels of bicultural harmony. In other words, high harmony buffered the negative effects of sexual victimization to symptoms. However, bicultural identity blendedness did not significantly moderate the relationship between victimization and both types of symptoms. And for our last hypothesis, social constraints moderated the relationship between victimization and somatic symptoms. So as you can see here, victimization predicted higher somatic symptoms only at high and moderate levels of social constraints, but not low levels of social constraints. We saw a similar pattern in social constraints moderating the relationship between victimization and psychological symptoms, though it was not statistically significant. P was 0.06. And just a few notes about our findings. We replicated findings that are consistent with the larger literature on sexual victimization and health, but in a sample of Arab American women, in that victimization experiences are associated with health symptoms. And our findings also coincide with prior findings that low bicultural identity harmony is associated with worse health outcomes. This could be because the construct of bicultural identity harmony tends to be related to, for example, elevated perceived distress. Also, higher harmony may serve as a protective factor in the process of post-victimization recovery. So that could also be the reason for why we see that the victimization and health symptoms are less related at higher levels of harmony. And we also replicated previous findings linking social constraints to poor adjustment and health symptoms in Arab American women, sample of Arab American women. And this may be related to the fact that social constraints tend to be linked with low disclosure, post-victimization, which may also be in turn related to lack of help-seeking behaviors. Some research implications. It's unclear why bicultural identity harmony varies across individuals, and similarly why individuals vary in their perceptions of social constraints. So this is an important thing to examine in future research. And some proposed predictors include these: so language barriers, discrimination, strained intercultural relations, or neuroticism, but these warrant further study. It's also could be helpful to examine the malleability or changeability of bicultural identity harmony, and this could aid in developing and testing potential interventions to increase it. And also to examine how bicultural harmony and social constraints are associated with other better known or better studied risk factors for poor outcomes after sexual victimization. So that includes things like low perceived control or negative responses to disclosure. So how harmony and social constraints may be related to these better known risk factors is unknown and warrants further study. Some important clinical implications. First, it's really important to study and clinically distinguish Arab Americans as a separate cultural group. Here in the US, Arab Americans in health research and in healthcare settings in general often categorized as Caucasian or white, which perpetuates cultural invisibility and does not take into account these important sociocultural factors. Also important to develop for Arab American sexual assault survivors culturally responsive interventions that assess for these sociocultural factors in clinical work, and also given the social constraints and perceived restrictions surrounding discussion of sexuality and sexual assault in the population, it's important to communicate safety and emphasize confidentiality in these discussions. And last, to utilize interventions that facilitate disclosure and emotional processing. Similarly, because there is a perceived constraint about disclosure surrounding this topic, it's important to elicit and assess for these types of experiences and to aid in emotional processing. Some important study limitations are sample of sexual victimization survivors is relatively small in this study, so future research should utilize a larger sample size. Of course, an important thing is that our victimization measure was dichotomized, so it doesn't allow for a nuanced study of the different types of experiences. And we also modified the measure of assault in that we assess for lifetime sexual victimization, and this modification is of unknown validity. I will note that the original study was not designed to specifically assess for sexual victimization and recovery. It was designed to test a disclosure intervention related to sexual health. So there's not really a lot of studies out there that are designed specifically to assess these types of experiences in Arab populations. So that's definitely a future direction. Immigration status was not examined as a moderator. Our sample of individuals who experienced assault and were also immigrants was very small, so we were not able to assess for this. And of course, data are cross-sectional in this study, so causal conclusions are limited. So overall, this is the message is that this Arab American represent population that may be at a special risk for adverse outcomes following victimization. It's important to assess for sociocultural factors, including the ones that we utilize like bicultural identity, harmony, and social constraints, and important to study and clinically distinguish Arab Americans as a separate cultural group. Thank you.
Thank you so much. Our next speaker is Tiffany Marcantonio.
Hi, everybody. Let me just get this. And I think everyone can see this. So hi, my name is Tiffany, and today I'm going to present some work that my colleague Malachi and I have been doing for the past year. So as I'm sure many people in the audience know, intimate partner violence is one of the most common forms of violence against women worldwide. And we do know that these rates can vary across countries, with higher rates seen in lower income countries. For this study, we're going to define intimate partner violence as including sexual or physical. And we know there are a host of consequences to experiencing IPV, including mental health concerns and self-harming behaviors. Because of how common intimate partner violence is, researchers spend a lot of time examining individual level predictors of intimate partner violence perpetration and victimization. And in that, research is focused on attitudes that support violence against women. And some work has also looked at the economic status of individuals and how this relates with intimate partner violence prevalence. However, as a field, we're really starting to expand how we think about factors or what factors might contribute to rates of violence. And so we're starting to think more as a field about these larger macro or sociocultural factors that can contribute to rates of intimate partner violence. And so the reason why we might be interested in these larger cultural societal factors is because we know intimate partner violence prevalence does vary across countries, which suggests that there could be, again, these like country level factors which contribute to individual rates of intimate partner violence. And so some of these cultural factors could be a country's attitudinal norms toward intimate partner violence, such that if a country has norms that support the behavior that support intimate partner violence, we might see higher levels at the individual level, or we might see higher rates at the individual level. Additionally, violence against women laws and policies can be related to prevalence rates of intimate partner violence, such that if a country has many laws or sanctions regarding violence against women, we might see lower rates of intimate partner violence at the individual level because it might suggest a priority for the country itself. And then finally, some more recent work has been looking at the economic development of a country and how this could relate to its rates of intimate partner violence. And so I'm just going to highlight a couple studies that have looked at economic development and its relationship with intimate partner violence. So one study found that rates of intimate partner violence varied across different societies and cultures. And in this study, they looked at correlates related to IPV, and they did find that one of them was economic development. However, the study was descriptive in nature and it didn't conduct any formal statistical analyses in it. Another study that used GDP, or gross domestic product, found that economic development accounted for about 30% of the variation in intimate partner violence, or 40%, I'm sorry, 40% of the variation in intimate partner violence. And this suggested that economic development was a correlate of intimate partner violence. There we go. Finally, one more study using GDP found that, again, when it accounted for economic development of a country, this counted for 30% of the variance in IPV prevalence for countries. However, in this study, they conceptualized attitudes and economic development on the same level. However, we began to wonder, what if there's a higher ordering effect occurring here, such that the relationship between attitudinal norms toward IPV and prevalence of IPV might vary by a country's economic development? And so that leads us to our current study, which is the goal is to look at if there's a potentially a higher order effect occurring via two sociocultural correlates. And so for this study, we're going to look at the influence of a country's IPV attitudinal norms and violence against women laws and policies, and the relationship that has with IPV prevalence varying across economic development. So our first hypothesis is that controlling for economic development, we would see in a relationship between attitudinal norms that support IPV and weaker legislation that targets violence against women would predict a country's IPV prevalence. We also hypothesized a hierarchical effect happening though, such that the relationship between attitudinal norms that support IPV and the legislation that targets violence against women would have a relationship with IPV prevalence that would vary based upon a country's economic classification. So regarding our method, this comes from a secondary data analysis from the Organization for Economic Cooperation and Development. So OECD is how I'll refer to it moving forward. In the paper, we do describe the data set in greater detail. For the sake of time, I'm not going to do that here, but if you have questions, I'm happy to answer at the end. So regarding what the sample is included in our study, we included countries that had all of our variables of interest, and that resulted in 98. And you can see that we have countries from across the globe. And of interest for this study, we have 4 different economic development groupings. So high income, upper middle income, lower middle income, and low income. And these groupings were created by using the United Nations definition for economic development. So regarding how our variables were assessed in the data set, these are the operational definitions that were given to us from OECD. So sexual and physical intimate partner violence was assessed by the percentage of women who suffered intimate partner violence, whether that's physical or sexual, during their lifetime. And this is on a 0 to 100% scale, with higher scores suggesting greater prevalence rates of IPV. And in our data set, that ranged from 6 to 78%. IPV attitudinal norms was assessed by the percentage of women aged 15 to 49 who consider a husband to be justified in hitting or beating his wife for one of these specified reasons. And that could include going out without telling him or refusing sexual relations. And again, this is on a 0 to 100 scale, with higher scores suggesting greater support for IPV attitudinal norms. And then finally, violence against women laws and policies. These were assessed by a team of researchers who developed the OECD measure. And what they did is they looked at a country's legal framework and they saw whether or not it protected women from violence experiences that included intimate partner violence, rape, and sexual harassment, with no legal exception or a comprehensive approach. So the researchers went in, they coded these policies and laws, and then they tallied them up or summed them up together. And then we multiplied that score by 100 so that it was on the same scale as IPV attitudinal norms and prevalence. And here, higher scores suggest a weaker framework regarding violence against women. And I want to highlight here that this is all at the aggregate level. So we do not have individual data. This is all at the country level, our data. So regarding our results, we did find that economic development accounted for about 13% of the variation in country level differences of IPV prevalence. And so according to hierarchical linear modeling, anything above 5% would suggest that you actually do have a higher order effect occurring in the data. And when we controlled for economic development, we did find that attitudinal norms toward IPV, but not laws regarding violence against women, predicted intimate partner violence prevalence. And so because laws were not related, we did not move forward with them in our models, and we only included attitudinal norms toward IPV. So here we can see that there's a linear relationship between IPV attitudinal norms and prevalence, such that as attitudinal norms increase, so as there's greater support for IPV norms, we see that prevalence rates increase as well. Now here we can start looking at our countries and their different economic development, and we still see that linear trend exist. However, when you group the countries by their economic development and you do that hierarchical classification, we actually find out that the relationship between IPV attitudinal norms and IPV prevalence is only significant in the lower to middle income countries. However, that relationship does not exist for the other three types of countries, economically developed countries. And so you might think of this as that we have three different sides to a story here. So for higher income countries, we don't see an association between IPV attitudinal norms and prevalence, and that's because both are low. Differently though, in the lowest income countries, we don't see an association between IPV attitudinal norms and prevalence because both are high. So you might suggest that we're experiencing a ceiling effect there. However, for your lower to middle income countries, we do see an association between IPV attitudinal norms and prevalence. And this might be due to the fact that these countries could be in a transitional time. And so you're seeing greater variability in how people, or the prevalence, you're seeing greater variability in IPV attitudinal norms, and then that is being related to IPV prevalence. So regarding what we found in summary, we found that there's an average prevalence rate of sexual or physical intimate partner violence across 98 countries at 30%. We did find that a country's attitudinal norms toward IPV was related to its IPV prevalence. However, a country's violence against women laws was not related to the prevalence of IPV. And then finally, we did find that a country's economic development was related to prevalence of IPV, such that the relationship between attitudinal norms and IPV prevalence depended on a country's economic development, and countries that were less economically developed had a higher prevalence of IPV. And so what our findings suggest is that in line with previous research, economic development does account for the relationship between attitudinal norms and IPV prevalence. Historically, researchers have looked at economic development and a country's attitudinal norms toward IPV on the same level. However, our findings suggest that there's actually a higher order effect occurring here, such that the relationship between attitudinal norms and IPV prevalence varies based on a country's economic development. And so these findings actually help to contextualize some recent work that's been coming out. So a recent study found that there wasn't a relationship between gender equality norms and IPV risk at the country level. However, all the countries included in that study were from the European Union, which in our study would have them classified as high income and upper middle income countries. And so the researchers might not have found a relationship between these norms and IPV prevalence because all of the countries in their data set were from the upper echelon of economic development. If they had countries that varied in their economic development, they might have found a relationship then, which is what our data suggests. Now, there are a couple limitations I do want to highlight to this study. So first, as others have suggested, the data is cross-sectional, so we cannot draw causality from these findings. Additionally, there are some important limitations to the data set that I would like to highlight. So first, sexual and physical intimate partner violence prevalence and attitudes towards this behavior were combined. So the questionnaire does not separate sexual and physical intimate partner violence attitudes or prevalence, so we weren't able to look at the two separately. Additionally, our data set only includes women in it. And I think that if we included men in this study, we might find different findings, particularly if we look at men's prevalence of intimate partner violence. We don't have individual data here. Again, the data is all aggregated at the country level, so we can't connect these to the individual at the end. And we're also limited by the data collection methods and governmental reporting, such that if a government doesn't report their prevalence rates of IPV, or let's say they underreport them, then our data set is limited by that as well. However, despite these limitations, we do think that our findings have implications for research and policy. So regarding research, we do think our findings suggest the benefits of using hierarchical linear modeling. So we could have done a traditional model within ANOVA where we had our 4 groupings of economic development and we looked at differences in attitudes or prevalence rates across countries. However, if we had done that, we might not have found that hierarchical effect that we did in our data such that attitudinal norms and their relationship with IPV prevalence vary depending on the economic development that you're looking at. And so by using HLM modeling, you're given a more nuanced picture here. And so we think that our findings suggest that moving forward, this type of modeling could be really impactful for sexual violence and intimate partner violence work. Regarding measurement, as I suggested in this data set, sexual and physical violence were combined, so we couldn't look at them separately. However, we certainly think that there is a worthy and warranted need to look at them separately, particularly because the correlates, protective and risk factors that relate to sexual and physical intimate partner violence, while there is some overlap, there are also different things as well. And so it'd be helpful to look at these two behaviors separately, so then we can look at the different correlates and consequences of intimate partner violence, whether that's sexual or physical, separately as well. Finally, we also think there's a need to expand how we're assessing sexual violence, certainly to extend outside of marital and cohabiting relationships, but also in expanding how we're assessing violence. So moving from completed rape into unwanted touching, catcalling, and harassment as well. Outside of research, we do think our findings have some policy implications as well. So in some countries, IPV is perceived as a minor social problem. And we think one way to address this is through media and advocacy campaigns that work to increase awareness of IPV. And we think these campaigns need to address boys and men in them. Certainly, we can take a bystander approach in that everybody has a role in preventing sexual violence, or we can talk about risk reduction and empowering women to own their sexual space and how they can prevent experiences of sexual violence. However, one gender is more likely to engage in perpetration, and it's important that our intervention and prevention tactics target this group as well. And so in thinking about that in terms of like what could be a policy initiative or what is something that countries could invest in, they could invest in and recommend and financially move money into gender transformative interventions. And so gender transformative interventions are interventions that aim to empower and free men and women from destructive gender norms. And the idea is they aim to do that by transfiguring or changing how we conceptualize gender to make a more equitable relationship between women and men. Because the idea is that gender is not who we are, it's something that we do. And so if we have learned maladaptive, problematic, traditional gender norms, we can unlearn those as well, with the goal of freeing women and men from gender and sexuality norms that negatively impact their health. Finally, I would be remiss if I did not end this presentation by highlighting that I'm currently on the job market. So my name is Tiffany, and I am a doctoral candidate at the University of Arkansas and a research affiliate of the Kinsey Institute. My research program is in sexual violence and alcohol use. If your institution is hiring and they think that they would like someone like me as a candidate, please let me know. I would love to hear from you. More than likely though, if you see my application come across your pile, I hope that you will select me. I would love to phone interview with you and hear more about your institution and talk more about the work I do as well. And with that, I will close out and thank you all for your time today. It's been a pleasure to be here with everyone.
All right, thank you so much. My name is Terry Weaver, and I'm a professor of psychology at St. Louis University. And I will be talking today about sociocultural influences on sexual violence recovery. So on the recovery side, as opposed to the experience side. I first want to do a shout out and thank you to my co-author, Emily Dworkin. She is also on our panel presenting another paper today. Emily brought tremendous expertise to this paper and has a large footprint on it. And so I am most appreciative of her collaboration. All right, so we started from the perspective that context matters. And so I'd like to start with a bit of an analogy here. To be a successful farmer, no matter how strong your seed stock, no matter how temperate your weather, one must know the nature of the soil. And so like the nature of the soil, we were exploring the nature of the broader cultural environment, sociocultural environment in which survivors find themselves embedded, and the ways in which that sociocultural environment impacted their mental health recovery. So in terms of our aims, we know that theory and research suggests that broader sociocultural environments do impact psychological recovery for survivors, but these factors have been largely untested. So we asked ourselves, really, what are those macro system level factors that confirm risk or may confer protection? And similarly, what are the mechanisms by which these macro system level factors operate? We are proposing today a conceptual model that is supported by both theoretical and empirical review of literature, and we've prioritized our research with ethnic minority and global survivors. Alrighty, so here is the overarching model, and we will be focusing today, as our paper did, up here on the macro system factors. And those macro system factors included norms, they included structures, and they included environmental stressors. And then collectively, we examined how those macro system factors may influence survival health, both in terms of looking at how sexual violence was thought about and subsequently responded to, and then how these collective factors introduced peripheral sources of stress or resilience, again, as an impact on survivor health. You heard in the last presentation the importance of study for norms in terms of incidence of sexual violence, and we actually found the largest body of research in these macro factors as also focused on norms as related to survival mental health. So when we talk about norms in our review paper, we were looking at sexual violence supportive norms, values and expectations, views of emotion, trauma and psychopathology, and oppressive belief systems. And I will be going into a little bit of detail on 3 of these 4 broad areas. All right, so when we talk about sexual violence supportive norms, what are we talking about? These include rape myths, traditional gender roles and patriarchal values, perspectives of survivors as damaged or irrevocably changed, and norms that emphasize virginity as being a defining feature of a woman. Each of these sexual violence supportive norms were associated with poor mental health in global samples of survivors, decreased disclosure, and decreased help seeking. In terms of different types of cultural values, we did see represented in the literature a range of different cultural values and how they impacted mental health. And I will focus here just on one type of cultural values to give you an illustration. So cultural values that encourage personal responsibility for behavior and that view the individual as responsible for the collective. And we've heard about that in some of the other presentations. The collective could be family, the collective could be a representation of cultural identity. Those cultural values were associated with more self-blame, more shame, and more stigma following sexual assault. I've included a quote here from a qualitative study of South Asian women who had experienced rape. As illustrative of this cultural value, this participant said, "Being raped destroyed my family's virginal status too, so to speak. It was a double blow, and I felt like I let my family down by what had occurred to me." In contrast, though, collectivist norms and racial ethnic identity could also be protective. So in that same qualitative study, we found a quote, "I feel proud to be South Asian. I have more access to resources and healing practices like yoga and meditation." Okay, the third of the 4 groups of norms that I'll describe today can be grouped into oppressive belief systems, and these are all the different types of isms. So racism, sexism, heterosexism, ableism. These oppressive belief systems can differentially constrain access to and equitable remedies. They can also compound impact following sexual violence, and they can propagate misinformation about sexual violence, as well as propagate bias and misinformation about sexual violence survivors themselves. Okay, so now in this part of the macro system, I want to turn your attention to structures. Structures include, but are not limited to, laws and policies, media, events, and movements. And these structures instantiate and institutionalize the sociocultural norms. Sorry. Sorry, I don't know why that's coming up. Is that blocking people's view?
We can see it okay.
Okay, perfect. Sorry about that. I had something that came up on my computer. These structures instantiate and institutionalize the sociocultural norms and values discussed before. So let me give you a couple of examples. So criminal codes as forms of laws may directly and indirectly affect survivors' access to criminal justice and social service remedies. Some of those criminal codes can include the definition of rape. So the criminal code may define certain types of sexual violation as meeting that definition or exclude other types of sexual violence. The criminal codes may also provide differential access to opening the doors to different funding streams for remedies, or they may close the doors to funding streams for remedies. And maybe perhaps what one might think of as somewhat more indirectly affecting survivors' mental health, survivors' documentation status and the criminal code surrounding those can have a huge impact on whether, for example, documented versus undocumented survivors have access to both social service as well as criminal justice remedies. Finally, we mentioned a number of different movements that have provided collective voice, vision, and community for survivors of sexual violence. Those include the hashtag Yo Tambien movement in Mexico. And we also talked about the hashtag #MeToo movement here in the States. That we also provided some critiques of the hashtag #MeToo movement and ways in which it may have not been inclusive and may have created really some exclusion and isolation for broader samples of sexual violence survivors. Okay, so the last area of macro system that I'll focus on are chronic and overarching environmental stressors, including things like wars and conflicts. We did write this before the COVID-19 pandemic, but pandemics generally, and certainly COVID-19 specifically, genocide, terrorism, and poverty. These global stressors compound the impact of sexual violence by creating additional stress, reducing availability of services and supports and spreading those supports very thin, and constraining and providing additional barriers to reporting. We also noted that the impact of these environmental stressors is significantly greater for those survivors who are already marginalized in different ways, creating, again, disparate access and poor mental health. Okay, so what are the implications of these findings? First and foremost, we are providing a conceptual model that we hope will be tested with empirical studies. And we hope that those studies will include authors who share the same global identities of the global populations of participants that they're studying, in such a way that we hope to avoid centralizing white American perspectives, which we recognize is into this conceptual model due to some of the representation of the research that was used to build it, as well as our own identities as authors creating this model. And in this way, we hope to similarly avoid centralizing whiteness as a normative. Second, we pose that psychological recovery from sexual violence, we hope that it will be considered within a multi-dimensional sociocultural context across multiple studies of sexual violence, even if that is not your primary aim of your study. Third, we want to promote that culturally situated research should center survivor voices and guiding research content and process, and that those survivor voices and their experiences play an important role in pushing our field forward and in changing and guiding these conceptual models. They should. Fourth, global research should not consider identities unidimensionally, but they should consider and explore multiple intersectional identities and the ways in which those intersectional identities frame the experience and recovery profile from sexual violence. In terms of clinical and policy exposures, we would like folks to consider both the direct and indirect policy impacts on sexual violence and survivor mental health. We explored and reviewed some policies that really on the face of it were intended to empower and open the door for sexual violence survivors, but downstream it was found that they actually disempowered violent survivors and had some unintended negative effects. So it's important to not only study policy initiation, but policy implications downstream. Next, improvement in norms, conditions, and structures, those macro system levels, may in fact constitute a trauma-focused intervention with broad public health impact. And then third, we encourage the amplification of the ways in which cultural identities may serve as forms of strength and resilience, and noted that really emphasize that strength and resilience side of things. So hope to see more of that. So anyway, I thank you all for listening to this brief presentation of our much longer paper. We are excited about the paper, hope you read it, and we welcome your feedback on our conceptual model. So thank you so much, and thank you to Heather for organizing this presentation.
Thanks so much. Our next presenter is Dr. Anna Segura.
Hi. Thank you, Heather. The previous presenters, my name is Anna, and I'm currently working at NYU as a researcher. And today I'll present an exploratory study we conducted with Dr. Noemi Breda from the University of Barcelona regarding child sexual abuse within the Roman Catholic Church in Spain. So 20 years ago, the world read a heartbreaking piece about child sexual abuse, perpetrated by the Roman Catholic clerics from the US Diocese of Boston, thanks to a journalist from the Boston Globe. Two of the most salient aspects about this type of abuse that came to light after the report was released were that the victims were mainly boys, and that the Roman Catholic Church as an institution already knew about these cases and swept them under the carpet, denied victims' experiences, covered the abusers, and even changed them from one parish to another one. So what started in Boston nowadays counts with tens of thousands of victims around the world. For example, many cases have seen the light in the United States, in Canada, in Australia, in Chile, in France. So we can say that child sexual abuse by Catholic clergy is an unprecedented issue of justice. In Spain, the problem has been almost non-existent. 5 years ago, Catalan journalists revealed multiple accusations against members of a religious school, as well as the lack of response by that institution. Later on, more journalists started to investigate this issue. So for example, 3 years ago, a popular newspaper opened an email address to gather victims' reports. And as you can see today, they reached almost 900 cases. However, journalists and researchers suspect that many of the victims are hidden, because in Spain, the Catholic Church still has an enormous power and control. Because as you can see here in the map, where media investigated, cases came to light, but wherever media did not, cases remain invisible. And finally, because the number of cases in Spain is significantly low compared to other countries, for instance, France. So that was the social context when we started our research project. But what do we know from the scientific field? So we know that studies reported the most victims are males, and that the consequences of this type of abuse are similar to those reported by victims at the hands of non-clergy persons. But on top of that, this abuse shatters the core beliefs in a benevolent and just world, which are important aspects of spirituality. In addition, most victims who disclosed these experiences to the church frequently encountered disbelief and blame and exclusion. Therefore, we agreed with our research colleagues that we should investigate this victimization as a separate and unique entity. Yeah, excuse me. The goal of the current study, the current exploratory study, is to describe clerical child abuse in Spain and how this data can inform practice in the future by describing these sexual victimization experiences, disclosure and report to the authorities, the impact of the abuse on their faith and spirituality, and other caregiver and sexual victimization experiences. So to recruit participants, we put a lot of resources and effort in it. So we worked with Spanish foundations serving child sexual abuse survivors, victims who had publicly disclosed this type of abuse, TV channels, newspapers, and radio programs to disseminate our survey and a 24/7 number linked to it, phone number linked to it. So after that many efforts, our sample comprised 38 adults, all of them survivors of child sexual abuse by a representative of the Spanish Catholic Church. As you can see, 25 males and 13 females. In order to gather data, we asked participants about their socio-demographic information, faith and belief system, and we used the juvenile victimization questionnaire to explore sexual and caregiver victimization experiences. So, looking at the results, we see that victims who experienced child sexual abuse by clergy reported that this experience started at the mean age of 12 years old, ranging from 5 to 17, and that this finished at the mean age of 14, ranging from 7 to 31. Approximately a third of them reported sporadic child sexual abuse, while the remaining reported that the abuse lasted a mean of 4 years, ranging from 1 to 16. In addition, the most prevalent sexual abuse type involved physical contact, for example, inappropriate touching or masturbation. Then, half of the victims reported the abuse involved penetration, and others indicated the abuse didn't involve physical contact. So, for example, sexual propositions, flashing, or exposure to pornography. As you can see here, percentages some more than 100%, meaning that some victims experience more than one type of child sexual abuse. So regarding disclosure, most of the victims explained the abuse to another person. So they disclosed the abuse at the mean age of 24 years old and to a mean of 2 confidants, usually to their mothers, friends, family members, partners, but also to church representatives or professionals, for example, a teacher, a doctor, or a psychologist. Regarding notification, almost half of the victims made a formal report to the authorities. And as you can see, most of them, almost all of them, reported the abuse to a representative of the Catholic Church, and less frequently to the police or to the legal system. Among those who reported to the authorities, overall satisfaction was 3 out of 10, which means that the authorities' response had a negative impact on the self-reported victims' well-being. As another piece of information, more than half of participants reported that being sexually abused by clergy had a negative impact on their belief in the church, in the Catholic Church, and almost half as you can see here, as almost half of them reported an extreme or considerable impact on their belief in God. Finally, we asked them about other co-occurring victimization experiences, both sexual and caregiver. And as you can see, they reported that in addition to child sexual abuse by clergy, more than half of them experienced other forms of victimization, with a mean of 3 victimization experiences. The most prevalent ones were physical and emotional abuse, neglect, and child sexual abuse by non-clergy persons. As you can see here in the left, in this yellow button, approximately 3/4 of those who reported child sexual abuse by non-clergy experienced it prior to the onset of sexual abuse by a church representative. Here in the middle, another data point is that all of those who experienced neglect did it while suffering sexual abuse by clergy. So, to sum up, our results from our descriptive study show that sexual abuse by clergy is a serious problem in Spain. Findings show that victims were generally males, which is likely to be a matter of opportunity, but other researchers have argued that female victims are still hidden. In addition, results show that this abuse was severe, at least lasting for months, and including behaviors with physical contact or penetration. About abuse disclosure, findings show that most victims required some time, if not years, before they explain their experience. And this makes me remember that we know that secrecy and exploitation of power are both components of institutional abuse, which may prevent disclosure, especially among males, due to its stigma. About notification, results also show that victims generally ask for help to the church rather than to other authorities. So we think victims expected the church to believe them and to take appropriate action. But as we saw, the institutional response was quite different. Regarding faith and spirituality, half of the victims reported that the abuse hasn't had a negative impact on their beliefs in either the church or God, which may reflect a feeling of betrayal and abandonment by the church. And finally, more than half of the victims reported other forms of child victimization before, after, or during the sexual abuse by clergy. Maybe we could think that they could be considered poly-victims. And another point to make here is that most of these victimization experiences at the hands of caregiver happened before the sexual abuse by clergy, suggesting that victims may have been chosen because of their vulnerability or lack of family support. As you know, and have seen, this study has a main limitation. So even though we did much effort to recruit as many victims as possible, our sample size is very small. And on top of this, it is likely that only those victims who are more critical with the church or who did not receive compensation regarding the abuse participated in the study. So there's room for improvement to study this unique type of abuse. Finally, the study has several implications I want to share. So we know that strategies that block opportunities, such as supervising clergy and children's interactions, can prevent sexual abuse. These strategies are starting to be implemented by the Catholic Church in Spain. So that's first gesture, first step. But other prevention strategies should be included. So for example, reducing permissibility by clarifying consequences and responsibility, controlling access by screening clergy for potential high-risk behaviors, or increasing the risk of detection by educating parents and clergy as well. At the same time, there is a need for the church to use protocols that provide clear instructions on how to respond when a disclosure of child sexual abuse is made. And finally, another implication of these results is the need to include the religious identity in the therapeutic setting due to the unique betrayal reported by its victims. So that was all. Thank you for your attention, and I'm happy to take any questions.
Thanks so much. And our final speaker will be Dr. Emily Dworkin, and then we'll have some time for a Q&A afterwards.
Thank you, Heather. All right. Can everybody see my screen okay?
Yes.
Okay, great. All right, so I'm going to be presenting on a systematic review that I did with my colleagues Barbara Krahe from the University of Potsdam and Heidi Zinzao from Clemson University. So as background for this paper, we know and we've seen in these presentations that sexual assault against adolescents and adults is a global public health problem, and it's associated with a wide range of negative mental and physical health outcomes. And so in light of the global public health burden of sexual assault, it's really important to understand the global prevalence of sexual assault in order to appropriately allocate resources and understand societal level causes of sexual assault and also develop effective prevention and intervention strategies. Unfortunately, most of the research on sexual assault has been conducted in the United States and Canada, which really limits our understanding of the global public health burden of adolescent and adult sexual assault. So what we wanted to do in this review was to summarize the global prevalence of sexual assault in adolescence and or adulthood for men and women outside of the United States and Canada. So to illustrate some of the epidemiological research that's been done on this topic, most of it has been done in the United States. And one of the more recent National Intimate Partner and Sexual Violence surveys, which is an epidemiological survey conducted in the United States annually, it's found that 18 to 21% of women and 1 to 7% of men had a lifetime history of attempted or completed rape. And 1 to 3% of women and 0.7% of men had experienced attempted or completed rape in the prior 12 months. And then when you're considering sexual coercion, which is a broader umbrella for sexual assault, which includes assaults that are not necessarily forced, 13 to 44% of women and 6 to 23% of men had experienced lifetime sexual coercion. And about 6%, 5 to 6% of women and 5% of men had experienced sexual coercion in the prior 12 months. And there's evidence of differences in the prevalence of sexual assault in various world regions. And as we've seen in some of these presentations today, various sociocultural factors that may differ across countries, such as cultural norms supporting violence generally or sexual assault specifically, as well as patriarchal norms, may account for some of these differences in prevalence rates. So there are fewer international epidemiological studies, but the World Health Organization's World Mental Health surveys, which were done from 2001 to 2012 in 24 countries, are an important exception to this. And these surveys assessed lifetime experiences of sexual assault and other traumas as part of assessing PTSD. And among women in high-income countries, the lifetime prevalence of sexual assault ranged from 2% to 26%, 2% in Spain, 26% in the United States. And among women in lower middle income countries, the lifetime prevalence ranged from about 1% in South Africa to 2% in Colombia. And several prior reviews have synthesized the data on the worldwide prevalence of sexual assault among women. And most recently, a review of worldwide non-partner sexual assault among women reported data from studies before 2011. And they reported a worldwide estimate of 7% lifetime prevalence for non-partner sexual assault among women. And lifetime prevalence varied across countries. And we've also seen studies indicating that the risk for sexual assault is elevated among LGBT populations in comparison to heterosexual populations. So why do we need to do another review? So the purpose of the current study was to update those prior reviews that I just mentioned with some recent worldwide findings on the prevalence of sexual assault. And due to the large number of studies focusing on US and Canadian samples and the underrepresentation of other world regions in the literature, we decided to focus just on world regions outside the United States and Canada. And in contrast to the literature review I just went over, which focused just on women, we chose to expand the focus to both women and men, as well as to studies that included both partner and non-partner violence, but we actually excluded any studies that were just of partner violence. And we also chose to include studies that were just focused on people that were LGBT to try to understand the prevalence in this very important and at-risk population. And we also tried to focus on prevalence estimates that took place after childhood in order to separate these experiences from childhood sexual abuse. So lifetime prevalence rates can be really widely varied and can make it hard to understand accurate rates of sexual assault occurring in adolescence or adulthood. And we wanted a more fine-grained understanding that reflected the different developmental stages when sexual assault could take place. So in terms of our methods for this systematic review, so we sought peer-reviewed studies that were published in English since 2010, which is about when the last reviews took place, that assessed the prevalence of adolescent or adult sexual assault in a country other than the United States or Canada. And studies including general population and college student samples were included because those are the predominant samples in studies from North America, so we wanted to be able to compare those. And we also thought that that would give us sort of the greatest generalizability. And student samples in particular were included because they're a frequently studied group with especially high risk, but this has not been reviewed globally. We excluded studies that only reported the prevalence of sexual assault in the context of intimate relationships, only reported the prevalence of sexual assault among a narrow specific population, such as sex workers or pregnant women, with the exception of studies that focus just on LGBT individuals. We excluded studies that only reported the prevalence of sexual assault among a combined sample of men and women. It didn't give us separate statistics. And we excluded studies that only reported on the prevalence of childhood or lifetime sexual assault. And we got 869 search results from which we obtained 177 articles that we reviewed in their full text. And ultimately we got 32 eligible articles reporting on 45 country specific studies. So in the results of our review, so this image represents the number of studies that were done in each global region. And noting here that only English language studies were included, but the total number of estimates was small, or the total number of studies was small, and it was distributed unevenly across world regions, with Europe and Africa making up 2/3 of the studies. There's no studies from Australia and New Zealand, and there's only one study from the Middle East from which we could garner prevalence data. More studies examined sexual assault rates for women compared to men, which mirrors the state of the evidence in North America. But it was really surprising to note that less than 1/3 of the studies were limited to women, which maybe reflects an increase in global attention to the problem of sexual assault among men. And in addition, we found that about half of our studies reflected the general population, a little more than 1/4 reflected students only, and about 18% reflected LGBT participants only. But 12 of the 19 LGBT studies came from Europe, which reflects a lack of attention to sexual assault in LGBT people in many countries outside the Western world. And I won't go into this in great depth, but we also characterized the risk of bias in these prevalence estimates. And we rated them on a 0 to 10 scale using kind of a standardized metric based on best practices. And the average risk of bias was about 6 out of 10, with 10 indicating maximum bias. But there are several methodological qualities of these studies that actually reflected some strengths in how they assess prevalence, as well as some notable limitations, which are described in depth in the manuscript. So I'll just get right into the prevalence estimates for the sake of time. So I'm going to be focusing primarily on the review results for past year sexual assault, given that the estimates for adolescent and adult sexual assault represent a much wider range. And so the estimates are a little bit less meaningful when aggregated. And we found that the prevalence of past year sexual assault against women in these studies ranged from 0% in China to 59% in Turkey. The prevalence of past year sexual assault against men ranged from 0% in China to 56% in Turkey. And among LGBT individuals, the prevalence ranged from about 2% in Mexico to 54% in Brazil, although that Brazilian study only included people with a lifetime sexual assault history. There were some differences in the prevalence as a function of study methods. So past year prevalence estimates tended to be higher in college student samples as compared to nationally representative samples. And we discussed in our paper how this might be due to the college environment, but could also be due to the age range in which people typically attend college, being a time of higher risk, and that we need more research on this topic to better understand how this works globally. In addition, there's a lot of variation in study definitions of sexual assault, and as would be expected, prevalence was higher when studies use explicitly inclusive definitions of sexual assault, like including both coerced and forced or attempted and completed, and prevalence was lower when studies used more restrictive definitions. And less clear patterns emerge as a function of whether sexual assault was assessed by interview or self-report. And this is perhaps unsurprising given that research has found not a lot of difference in rates of disclosure of sensitive information as a function of interview versus self-report methods, but there might be cross-cultural differences in this that we weren't able to characterize in this paper. And then a few kind of country-specific results. So 11 studies reflected countries in Africa, and there were multiple estimates reported for women, but few reported for men and LGBT. So this map just includes the estimates for women, which range from 5 to 38% past year prevalence. In terms of the studies using nationally representative sampling designs, there's a 5% prevalence in Swaziland and 14% in Malawi. And then in Asia, there were 7 studies that contributed information on past year prevalence ranging from 0 to 59%. And none of these use a nationally representative sampling design. 21 studies reflected European countries for past year prevalence. Among the studies using a nationally representative design, past year prevalence ranged from 1% in Spain to 2% in the Netherlands. And 4 studies reported past year prevalence for men, and among those using a nationally representative design, the prevalence ranged from 1% in Germany, or 0.6% in Germany to 0.7% in the Netherlands. And in Latin America, 6 studies reported on past year sexual assault. And there's only 1 study of past year prevalence in women, which reported 5% in Brazil. So in terms of kind of considering these results, so there were some limitations of our review design. So we only were able to include studies published in English, and it's possible that relevant articles were published in other languages. Although the lack of research on this topic from some English-speaking countries like Australia was notable. The review was limited to studies published in peer-reviewed journals, and such studies were less than 10% of the estimates included in the prior review in 2014. So it's likely that many other prevalence estimates are likely to be available in other outlets which weren't considered by our study. In addition, we didn't include any studies that focus just on sexual assault by intimate partners. But in countries outside North America and Western Europe, intimate partner violence against women has gotten a lot more research attention than sexual assault. And we decided to exclude this because this literature has been covered comprehensively, but it's still a limitation of what we included. So some quick implications. So first, a big priority for a global research agenda on the comparative prevalence of sexual assault should be to assess prevalence in multiple countries using standardized data collection protocols. And we did report on several studies that did this, but we think that more research needs to be done on this, especially outside of Europe, where many of these multi-country studies took place. And in particular, there should be studies in regions where there hasn't been a lot of attention to prevalence, like the Middle East, Australia, and New Zealand. And then Finally, it's important, as was reviewed in the prior presentation, to understand country and sociocultural context-specific risk and protective factors that could explain these differences in prevalence rates. And I will end it there.
Thanks so much, Emily. We do have some time for discussion. There were a couple of questions in the chat that can get us started. And I believe if you raise your hand, I think that Megan might be able to unmute you. I'm not entirely sure. Yes, Megan.
I can do that.
Oh.
Can you hear me?
Yes, now I can hear you.
Oh yeah, I'm able to do that.
Awesome, yes. So we'll start with the ones in the chat. There first was a question for Jillian. Yeah, she's still here, great. So there was a question about how rape and sexual assault were defined in the YRBS. So how was it assessed?
Yeah, really great question. Also great presentations by my colleagues here. It's really exciting work that's being done on the global scale. So just to answer this question briefly, I'm just pulling up our manuscript here. So lifetime, these were yes, no questions. The first one is lifetime rape was assessed with, have you ever been physically forced to have sexual intercourse when you did not want to? Sexual victimization was assessed with, during the past 12 months, how many times did anyone force you to do sexual things that you did not want to do? And then it was asked, that same question was asked in the context of a dating relationship. A similar question was asked related to physical victimization in dating relationships. During the last 12 months, how many times were you, did someone who you were dating or going out with physically hurt you on purpose? And those last three questions ranged from 0 times where I did not go out with anyone to 6 or more times. We dichotomized them in our study for the purposes of our analyses. But I suspect that the question is getting at some potential underreporting by youth in this sample, which is a really great point. And we know that behavioral assessments that are more nuanced than asking someone how many times a particular event happened may have led to some underreporting among this sample. So really, really great question, and certainly future directions for research should address some of these measurement issues. I don't know if anyone else wants to speak to some of that, or we can move on.
Great, and we also had a question from a faculty member in Mexico who I know she had something they had something in the chat before about sexual violence underreporting in that country, and so sort of what might be some good first steps for combating sexual violence when you're in a context where the vast majority of sexual violence does not go reported to any sort of authorities. And I think that's a question for anyone to chime in on.
I guess I'll just jump in as some ideas. So I think certainly not having reporting be a bar for access. And I think really developing some more of the peer supports and peer and family, perhaps, or other peer networks as networks of intervention or networks of support could be a way to begin to make some inroads into providing access without requiring a formal report or a formal acknowledgement of the individual. And so I think embedding those in networks is a good place to start, and looking at peers, maybe one avenue.
I know Tiffany had to hop off, but at the end of her presentation, right, she was talking about sexual IPV, but it also probably applies to sexual violence more generally, right? So interventions that are designed to moving the needle on social norms and understanding of sexual violence might be a great way to start. So more public education campaigns or embedding messages in popular media might be another way to sort of start moving the needle on things, in addition to equipping people's informal social networks with tools to intervene and assist survivors, as Terry said. And then I would say too, for those who are formal providers like healthcare providers, making it a practice to ask about those experiences in a gentle way and to repeatedly ask and to make it clear that this is a place where you can talk about these experiences confidentially and get support and help and make it an ongoing conversation, recognizing that in those contexts, survivors may not feel comfortable disclosing the first time you ask them those questions. And so we had another question in the chat from Valerie G. Mentioning that we didn't have any men who were speakers, and we did have men who were co-authors, but they weren't able to speak today. And yeah, so a question is, men who study sexual violence. I mean, I would say there are certainly men who are interested in this topic and are allies, though if we look at the field of sexual violence research, I would say it's probably more common for women identified folks to be in that field. But yes, there certainly are men who are in the field as well. I thought I saw another question. Oh, here it is. It was in the chat, sorry. Sexual violence in the prison system. And then, and a great question too, right, about not only sexual violence in prison, but people who experience sexual violence prior to entering prison, which we know is a problem. And then how do, what avenues for help are available for folks who are in the prison system?
I guess I'll jump in. Well, I think there is just a whole dearth of mental health interventions within penal settings, and those that are trauma informed are even more scant in those settings. So it is a huge gap. And, there is some research or qualitative work that has also looked at how different aspects of incarceration exacerbate PTSD symptoms and trauma experiences that occurred prior to, even if there is not a new assault within that context. So I think I don't have an answer. I just have, echo that comment that it's really a significant issue, and right now has gotten really a lot worse because of COVID, and there's just a real lack of progress in moving cases forward. So folks are incarcerated longer before their case is even moving forward, and they're incarcerated in settings that were not originally designed to be long-term incarceration settings, but more should be holding settings. So I don't have an answer, but to echo that issue and to say that it has been exacerbated, I think, by COVID.
I could just add briefly that Dr. Melissa Zielinski at the University of Arkansas Medical System is studying the implementation of evidence-based trauma-focused interventions or treatments for PTSD in prison settings, and she would be a great person to connect with if you have questions about that.
Yeah, we know that in the US that, right, the largest, when I teach abnormal, I always point out that what's the largest mental health care provider in the United States? It's the prison system. So unfortunately, we have a system where the people with mental health issues, particularly serious mental health issues, who also have very, very high rates of trauma, including interpersonal violence like sexual assault, get their care in the prison system. So often for committing some sort of petty crime, they end up in the prison system, and that's where they're getting their mental health care. So clearly, this is the system that's set up in the US. So the more that we can provide evidence-based interventions and assistance to folks, if this is the way the system is operating, that is where folks are getting mental health care. And then someone in the chat also mentioned the legal standpoint that there is the Prison Rape Elimination Act with a link to that act and resources, which could be really helpful for folks who are interested in learning more about that topic and sort of the legal side, what's being done in the United States. Let's see, I think. Yeah, so folks are asking for links to the models and everything. So you can find far more information about all these presentations in the special issue of Psychology of Violence. So if you have an academic affiliation, you certainly can get access to the article. If not, you can contact the authors directly and they'll be happy to send you a copy of their article. All right. Well, thank you everyone for attending today, and thank you so much for our speakers, and thank you for bearing with me with my technical difficulties. It's not a virtual symposium without technical difficulties. Thank you everyone and have a wonderful day.